Guys, welcome back again. Today I'm going to talk to you about another important medical topic which is called tuberculosis TB. What is tuberculosis? Is a potential serious infectious disease that mainly affects your lungs and that may also affect other organ of the body, mainly caused by Mycobacterium tuberculosis. Now in this video I'm going to talk about pathology and pathogenesis of tuberculosis, clinical feature, the pulmonary and extrapulmonary clinical feature, factors and investigations, complication with management. Let's jump to pathology and pathogenesis of Mycobacterium tuberculosis, but before that I'd like to talk about Mycobacterium bovis. Mycobacterium bovis infection arise from drinking non-sterilized milk from infected cows, while Mycobacterium tuberculosis spread through or by inhalation of aerosol droplet nuclei from the infected person. What does it mean? It means can be spread from one person to another. It can only be spread through air droplet originating from a person who has disease, either by coughing, sneezing, speaking, or singing. And now let's turn to know pathogenesis of the Mycobacterium tuberculosis. When you once inhale it, it will lodge at the alveoli and then initiate of recruitment macrophage and lymphocyte, and then macrophage undergo transformation to epithelioid and Langerhans cell, aggregate with lymphocyte to form a tuberculous granuloma. Aggregate of numerous of tuberculous granuloma, it will form primary lesion, or what we can call gone focus, a pale yellow caseous nodule at periphery of the lung. After gone focus is formed, organisms start to spread to the hilar lymph node, and then it causes a combination of primary lesion and regional lymph node, is referred to as the primary complex of rank. Then reparative process, in case the primary complex in a fibrous capsule, its point, limit bacilli spreading. Okay, and then calcify eventually and seen in chest x-ray. Lymphatic and hematogenous spreading may occur before immunity is established. Inciting secondary foci in other organs like lymph node, liver, meninges, kidney may occur. If reparative process fail, primary progressive disease ensure, which is first of all spread from the primary focus to hilar and mediastinal lymph node to form primary complex, which heals spontaneously in most cases. The second one is a direct extension of the primary focus, progressive pulmonary TB. The third one is spread to the pleura, which is TB pleurisy and pleural effusion. The fourth one is blood-borne spread, which may spread to the GIT, skeletal, pulmonary, and brain. And let's turn to talk about a clinical feature. Clinical feature, we have pulmonary and extrapulmonary. Let's talk about pulmonary. Pulmonary, we have primary pulmonary TB, miliary TB, and post-primary pulmonary TB. Primary TB refers to an infection of a previous uninfected individual, tuberculin negative. It's very important to know. Clinical disease occur only if there is a hypersensitive reaction or progressive infection. And the second one, which is miliary TB, blood-borne dissemination, gives rise to miliary TB characterized by 2 to 3 weeks of fever, night sweating, anorexia, weight loss, and dry cough. Is very important to know. And headache may indicate meningitis, anemia, and leukopenia reflect to the bone marrow involvement. On auscultation of the chest is normal, but in advanced cases, widespread crackle is evident, and on chest X-ray, fine 1 to 2 millimeter lesion spread throughout the lung field. The third one, which is post-primary pulmonary TB, refers to exogenous and endogenous. Exogenous, new infection, while endogenous, reactivation of a dormant primary lesion in a patient who has been sensitized by aerial exposure, most frequent and characteristically kind of the upper or apex of the upper lobe, where oxygen tension favors survival of strictly aerobic organisms. And onset is gradually over several weeks. Clinical presentation or clinical of the post-primary pulmonary TB, again, fever, weight loss, night sweating, malaise, accompanied by progressive pulmonary symptoms. What does it mean? What's progressive pulmonary symptoms? It means a chronic cough, often with hemoptysis, pyrexia, spontaneous pneumothorax, exudative pleural effusion with unresolved pneumonia. On chest X-ray, there is opacification of one or both upper lobes of the lung, cavitation and collapse. Collapse may be marked, and significant displacement of the trachea and mediastinum. And now let's turn to know factors increasing the risk of tuberculosis. We can divide it into two parts: patient-related and associated disease. Patient-related, we have age of the patient and overcrowding, smoking, close contact of a patient with smear positive pulmonary TB, and primary infection less than 1 year previously. And on the other hand, we have associated disease. In associated disease include immunocompromised patients like HIV, and malignancy, Davidson mellitus, chronic kidney disease, and GIT associated with malnutrition, deficiency of vitamin D or A, and finally recent measles in children. And now let's talk about complications of the chronic pulmonary TB. We have pulmonary and non-pulmonary complications. Pulmonary complication, we can say bomb cell. Okay, B stands for bronchopleural fistula, O for obstructive airway disease, M for massive hemoptysis, B for bronchiectasis, C for core pulmonary, E for emphysema and fibrosis, L for lung calcification. And about non-pulmonary complication, we can say 2A, 2EL. 2A, 2EL. 2A stands for anorectal disease from swallowed sputum and amyloidosis, while E, first one for empyema, the second for enteritis, again from swallowed sputum, and L for laryngitis. There are all about pulmonary or tuberculosis regarding pulmonary, but now we have extrapulmonary, which is account 20% of cases, and mostly in HIV positive patient. And extrapulmonary may include lymphadenitis, gastrointestinal tuberculosis, pericardial disease, CNS, joint, bone, and genitourinary. Let's talk about lymphadenitis. The most common extrapulmonary site of disease is lymphadenitis, which is cervical and mediastinal gland mostly affected, followed by axillary and inguinal supraclavicular lymphadenopathy, often result from mediastinal disease, while the node is the painless and initially mobile, but then matted together with time. When caseation and liquefaction occur, the swelling become fluctuant and may discharge through the skin, called collar stat. In this time, tuberculin test strongly positive. Let's talk about gastrointestinal tuberculosis. It can affect any part of the GIT, but mostly affected ileocecal origin. Okay, the patient has the same sign and symptom of the tuberculosis, like fever, night sweating, weight loss, anorexia, and elsewhere. And but there's a important point you have to know about it, which is when you have mass in the right iliac fossa, you have to put tuberculosis in your differential diagnosis, because tuberculosis, when it affects gastrointestinal, it leads to formation of mass in right iliac fossa. Okay, and in the differential diagnosis, we have Crohn's disease. You have to exclude Crohn's disease from the tuberculosis. While in pericardial disease occur in two forms: pericardial effusion and constrictive pericarditis. Shortness of breath, abdominal swelling are present, and pulsus paradoxicus, raised JVP, hepatomegaly, peripheral edema, and prominent ascites are present in both forms. But usually in pericardial effusion is frequently blood-stained. And what about CNS, central nervous system? As meningeal disease is most important form of CNS TB, and clinical features include headache, as I said before, depression, delirium, and behavioral change. And what about bone? The spine is the most common site of bone TB. It has a specific term called Pott's disease, present with chronic back pain, typically involving lower thoracic and lumbar spine, and kyphosis eventually if it leaves untreated. And it has a psoas abscess and paravertebral abscess formation is common. One of the differential diagnoses is malignancy, and common complication include vertebral instability and core compression. And what about genitourinary? Hematuria frequency and dysuria are often present, and pyuria, sterile pyuria, are often found in microscopic and culture, while in men cause prostatitis and epididymitis. In women cause salpingitis and infertility from endometritis. And what about investigation? What shall I do when I suspect he or she get tuberculosis? First of all, microscopic, direct microscopy of sputum. At least need 2 sputum in the morning, and spontaneous produced deep cough should be obtained. The second is bronchoscopy and lavage or aspiration of the lymph node. The third one is positive smear is sufficient for diagnose TB, but definitive diagnosis require culture. The fourth one is a negative smear should be cultured, as only 10 to 100 viable organisms are required for sputum to be culture positive. Another investigation is chest X-ray and CSF ascitic fluid aspiration. For extrapulmonary tuberculosis also need culture and histopathology. Let's talk about management of tuberculosis. Is a chemotherapy, and standard treatment involves 6 months. You have to give isoniazid, rifampicin, ethambutol, pyrazinamide. For those patients who are smear positive and smear negative, but typically X-ray changes, except for those who in case of meningeal case of TB, you have to tell a patient you need to continue for 12 months. In these cases, and ethambutol may be required or may be replaced by streptomycin. And there are some important notes we have to put it in our mind. The first of all, pyridoxine should be prescribed for pregnant women. Second one is ethambutol and streptomycin should be used with caution in renal impairment. Baseline liver function test and regular monitoring is very important with standard treatment. Rifampicin cause asymptomatic hyperbilirubinemia. And the fifth one is isoniazid and pyrazinamide cause hepatitis. And finally, we have glucocorticoids, reduce inflammation and limit tissue damage. So currently recommended when treating pericardial disease and meningeal disease. Finally, we have surgery should be considered in a case of massive hemoptysis, loculated empyema, constrictive pericarditis, cord compression, and spinal disease. That's all about TB. It's very important. Don't forget, please, what's TB, pathology and pathogenesis, sign and symptom, investigation, how to diagnose it, or complication, pulmonary and extrapulmonary, and those important notes that I mentioned in management of tuberculosis. Thank you for watching this video. Please don't forget to make dua for me.